Hi everyone, my name's John. I'm a nurse practitioner, certified in both in adult gerontology, ACNP, as well as family nurse practitioner. And I was asked by the Facebook AG ACNP board review group to go over some test questions. Just to give you a little background about myself, I'm a nurse practitioner. I have 18 years experience as an NP with over 20 years as a nurse. I have been working pretty much entirely acute care under my F&P license up until recently when I found out that was a no-no. So I had gotten my acute care NP just passed about a week ago, and the group asked if I could go ahead and go over some test questions. So what I have pulled up is the sample test questions from ANCC. About every quarter or so they release new test questions. Some can be part of the testing that you'll see on your actual exam. And so it's always a good idea to go over these test questions. So what I've done, I've pulled up the first 5 questions for this quarter's test. And again, this is the beginning of November of 2019. And we're just going to go through the first 5 questions in a bit of detail, go over what could be the right answer, what is the right answer, and what could be the wrong answers, and the thought process. Because remember that this test is kind of a psychological test as well. They want you to think like a nurse practitioner, not just have the rapid fire answer of if I see A, I need to do B. You need to think of why we're doing this. And so we're going to go through that in a bit more detail. So on the screen, we have the first question on the samples. Let's just go through this. When discharging an 85-year-old patient with stasis dermatitis, the AG-ACNP includes instructions to A. Keep the legs elevated while seated. B. Maintain systolic blood pressure greater than 120 millimeters of mercury. C. Soak legs in warm water daily. Or D. Wear compression stockings of 65 millimeters of mercury below the knee. So let's pick this question apart. So what are they asking? Age doesn't really matter. So we have a patient with stasis dermatitis. So the first question is, what's stasis dermatitis? Often commonly recognized as cellulitis for some people. It's this kind of stuff. So you see an older person come in, they got these big, thick legs that are swollen, kind of crusty looking. They got this yellow crust on it. I think I got some more pictures of what it looks like. You guys have all seen this. Very, very common in an older adult, especially someone with heart failure. You can just get some mild redness, some mild bruising, and can go all the way up to this poor lady here who has really thickened legs with this crust on it. And that's stasis dermatitis. Basically, it's an inflammation of the lower legs from venous insufficiency. So varicose veins, quote-unquote poor circulation. You see a lot of this in heart failure patients, especially chronic left-sided heart failure or more of an acute or right-sided heart failure. They both will show this. Okay. So we know what we're looking at. So stasis dermatitis, the chronic swelling of the lower extremities, usually from heart failure or venous insufficiency, varicose veins. So what do we need to tell the patient as they're going home? This is home. Okay, so what can they do at home? So when I look at test questions, I try to eliminate the 2 obvious ones that are wrong off the bat. Okay, so looking at the 2 obvious ones, I look at number 2 or B, blood pressure greater than 120. Okay, this is a venous arterial blood pressure. Really doesn't have a lot to do with it. At least, if I do A, B will get better. Okay, because you in theory could have an issue with this. Like, for example, if you have bad hypertension with heart failure, of course, for heart failure, you want to try to get the blood pressure less than 120. But Is this going to make an immediate impact on the patient? Probably not. So we can probably get rid of this question here. And just as an aside, I found this out when I tested the other week. When you go through your tests, you can right-click on an answer, and that will cross it off. So it's a lot easier when you say, oh, that's not right, and I can right-click on it, and that immediately is lined out, so I don't think about it anymore. Okay, so we know this one is probably not right. The next one that's probably not right is, I would say, C, soak legs in warm water daily. Okay, so we have a dermatitis problem. So we have chronic inflammation, we have broken skin, we have crusts on the skin. Soaking it in warm water daily, it may sound right, but my concern would be the risk of developing infection, having it constantly wet and moist, especially in an area where there's a lot of extracellular fluid floating around. The circulation's not that good. The risk of developing infection, possibly going to gangrene, would be much higher. So I would probably get rid of this one as well. So we can say both these two are probably incorrect. So what do we have left? Keep legs elevated while seated. Sounds good. Keeping the legs up helps drain that the venous blood that's not being pumped up to the heart from varicose veins. So yes, keeping the legs elevated will definitely help. And the next one, wear compression stockings of 65 millimeters or greater below the knee. That also is a correct answer. I was going through WebMD, of course, everyone's favorite site. And if you look at the treatment, wear compression stockings, keep your feet elevated. They're both correct answers. However, which one is most correct? So like Barkley says, the most correct answer is the cheapest and easiest answer. So keeping your legs elevated doesn't cost you a dime other than just having a chair, which vast majority of people have. Second one, compression stockings. Good to have. They're expensive. Compression stockings are 50, 60, even higher bucks per pair. So some people probably could not afford this or have access to it. So the correct answer, and the correct answer according to ANCC, is A, keep the legs elevated while seated. Okay, let's go on to the next question. A young female patient arrives at the emergency department with a vaginal discharge. After performing a pelvic examination, the nurse practitioner documents which finding. Okay, so let's look at the keywords here. Young female patient, okay, comes to the emergency department with vaginal discharge. You did a pelvic. Okay, so what kind of objective findings would you document on a pelvic that's abnormal? Okay, so let's look at our choices again. I'm going to skip A. Let's do the two obvious wrong ones. Positive bowel sounds. If I'm doing a pelvic, I'm not listening to her belly. I would probably get thrown out of the room if I was doing a pelvic examination and then tried to listen to her abdomen with a stethoscope. I don't think that would really be the right answer. Okay, let's look at number 4, positive rectal tone. Do you stick your finger into her rectum when you do a pelvic examination? No, that's not part of a pelvic. So we know that B, positive bowel sounds, are incorrect. And D, positive rectal tone, is incorrect. Because we're looking at a pelvic exam. So let's look at A and C. A, cervical motion tenderness. That is a positive finding that we see on a pelvic exam. B, pink vaginal mucosa. That is also something that we look at a pelvic exam. However, which one is related to the discharge? Which one is abnormal? And there we have it. A, cervical motion tenderness. For those who forget about the pelvic exam, because I know AGACNP does not do a lot of pelvic exams. I had to do it as a family nurse practitioner. That was fun. But remember, a pelvic exam is where you put your right hand on top of the mons pubis, right above the pubic bone, and push downwards on the uterus. And then with your left hand, you have your finger up, or you can do it opposite way depending on which handed you are, and feel the cervix. The cervix should be firm, it should be smooth, and it should be non-tender when you palpate it. She should not be screaming at you when you do it. So again, got your fingers up top, on the top of the fundus, and the other fingers on the cervix. And that's how basically we do a pelvic exam, and that's what we're looking for, is that she would have, if she had something, cervical motion tenderness, she has pelvic inflammatory disease from whatever bugs are growing in there. Let's look at the third question. A patient has hyperactive reflexes of the lower extremities. The nurse practitioner assesses for ankle clonus by A, applying a low-pitch tuning fork to the lateral malleolus. So basically you're putting a tuning fork to your ankle. B, sharply dorsiflexing. Okay, we have to recognize what dorsiflexing is. That means you're pushing the heel of the foot up toward your nose. So you're trying to push toes to nose and maintain the foot in this position while supporting the knee. C, striking the Achilles tendon with a percussion hammer after flexing the leg at the knee and rotating it externally. And D, stroking the lateral aspect of the sole with the sharp end of the percussion hammer from the heel to the ball of the foot. Okay, so let's dissect the question again. Hyperactive reflexes, so we're looking for something quivering or shaking or being extremely positive when you get that reflex. And we're looking for ankle clonus. So this is what they're testing for. What is ankle clonus? To be honest, when I took this sample test, I have no idea. I don't do orthopedics. I do pulmonary and cardiology. I have no idea what ankle clonus is. So I found a good
This video will introduce
video of ankle clonus. So here's a good example of what happens. So the examiner is going to lift up the foot, and then the examiner will dorsiflex that foot, and that's what it does. That is ankle clonus. That's the involuntary movement of the foot after you dorsiflex it. This usually happens after a spinal cord injury with increased spasticity. So that is what ankle clonus is. So looking at these 4 questions again, applying to the tuning fork to the ankle, that's not it. Striking the Achilles tendon with a percussion hammer after flexing the leg and rotating it externally, not it. Because we saw from the video, we're trying to dorsiflex. Hitting it down here and then externally rotating, that's really not going to do much for us. That's really not a reflex that I am familiar with. And then the last one, stroking the lateral aspect of the sole with the sharp end of the percussion hammer from the heel to the bottom of the foot. Now that is a reflex that we're familiar with from going, taking our percussion hammer and going all the way up here. What's that? That's Babinski's. Remember, we're trying to get the toes to curl when we do that, not ankle clonus. So again, this is one of those trickier questions where you sort of have to know what ankle clonus is to get this correct. And again, it's one of these weird things that the test does. Sometimes they just pull stuff out of thin air, and hopefully you know what it is. But that's the key to answering this question, is knowing what ankylosing is. You can always try to guess what it is because you look at the answers and you say, well, I know that the tuning fork is kind of silly, and I know that stroking the lateral aspect of the sole is Babinski's, so I know that's not it. So it's either going to be this one, B, or this one, C. You could probably get rid of C because, rotating the leg, messing around with the foot, that just seems kind of odd. Usually when we rotate the leg, again, remember when we do that, when we push up on the knee and rotate it, we're either looking for appendicitis or we're looking for meningitis, not so much with a clonus, the hyperreflexivity. So based on that, you probably could guess this even if you didn't know what ankylosing was. All right, let's go to number 4. A patient with a history of heart failure arrives at the ED showing shortness of breath and lower extremity swelling. Both of the patient's symptoms are a result of A decrease in plasma oncotic pressure, B, an increase in capillary hydrostatic pressure, C, an increase in capillary membrane permeability, or D, obstruction of lymph drainage. Okay, so let's dissect the question again. We got a guy with a history of heart failure. Okay, what happens with heart failure? We have left and we have right-sided heart failure. Both left and right will give you lower extremity edema. Shortness of breath is more of a left-sided heart failure because the left ventricle cannot squeeze out as much volume that's coming into it from the lungs, and therefore we have increased pressure getting into the pulmonary arteries and working our way backwards through the right ventricle, right atrium, the vena cava, both inferior and superior. So we'll see elevated JVD, the anasarca, and then lower extremity edema. Okay, now keep that in mind. It's increased pressure from that we're recognizing. So symptoms are a result of decrease in plasma oncotic pressure. So what is plasma oncotic pressure? That oncotic pressure is the diffusion pressure of the plasma. So the more protein we have in our plasma, the more albumin, it has an increased oncotic pressure. So basically it sucks water into the vascular space, right? Low oncotic pressure would release that fluid and would get in the intracellular space, okay? So we have a decrease in pressure, so that may be it. We have an increase in capillary hydrostatic pressure, so we have more fluid pressure, more fluid pressure in the capillaries. C, increase in capillary membrane permeability. Okay, so does the wall between the intravascular and extravascular space, is that permeated? Is that allowing more fluid back and forth? In heart failure, no, it does not. So we can definitely get rid of this question. And then D, an obstruction of lymphatic drainage. Lymphatic drainage, we know, does have some extracellular component. It sucks. It's a low pressure system. Takes that extracellular fluid and dumps it into the superior vena cava or inferior vena cava. But we know it's not that. It would typically be unilateral if we're seeing lymphatic drainage, and this is, I believe they're saying it's bilateral lower extremity swelling. We can get rid of this one, okay? So we don't have increased permeability. We do not have an obstruction and drainage. Okay, so let's look at A and B again. These are two that could possibly be. So a decrease in the plasma oncotic pressure. So again, let's look, here we go. I got it pulled up on Wikipedia. Oncotic pressure induced by proteins, albumin within the blood that displaces water molecules, creating a relative water molecule deficit. Okay? So, the increased pressure means the more fluid is going to suck in. So again, this is decreased, so the plasma is not pulling in fluid. Okay? Or B, an increase in capillary hydrostatic pressure. So both of these could be it, but when you look at B, when we say capillary hydrostatic pressure, remember when I was saying before with left and right heart failure, the left ventricle cannot pump out the fluid that is coming into it. So the pressure behind that left ventricle slowly rises and it transmits through the body down to the capillaries. When we get down to the capillary level, the increased pressure of the venous system forces fluid out into the extracellular space. And that's where we get our swelling and our pulmonary edema from. So B, increase in capillary hydrostatic pressure, is the correct answer. Okay, and let's look at our last question, 5. Temporal arteritis requires immediate treatment in order to prevent A, blindness in the affected eye, B, facial nerve palsy, C, TIA, and D, trigeminal neuralgia. Okay, so again, the key is knowing what temporal arteritis is. Temporal arteritis is the inflammation of one of the arteries feeding the head around the eye area. So we look at here, it's this artery over here that gets inflamed, and you'll see it. Let's see if I can get this a little bigger. You can see it like that. See how it's inflamed and red. The patient will complain of severe headaches, especially unilateral headaches, and this is something very important to recognize if you see this. I've only seen one case in 20 years, but then again, I work cardiology and pulmonary. I do not see it very often, but I have seen one case. So what's happening is that artery is becoming inflamed, and with the increased inflammation, you have decreased amount of blood flowing into that artery. So what would happen if we had decreased blood from increased inflammation? So A, blindness in the affected eye, possibly. B, facial nerve palsy, maybe. So facial nerve palsy means that the innervating nerve to the face, which is a motor nerve, would not work because of lack of blood flow. That's a possibility. TIA, possible. You are getting a inflammation in that artery where you could get some blood clots to form, possibly causing stroke, possibly causing TIA. Again, it's a possibility. And then trigeminal neuralgia, basically pain in the trigeminal nerve. Okay, so temporal arteritis, and we need immediate treatment. Okay, so which one of these is an emergency? Facial nerve palsy, not an emergency. Trigeminal neuralgia, it hurts, but it's not an emergency. TIA, not an emergency, but is something that needs to be looked after. Blindness in the affected eye, that is an emergency. Because if you get a patient complaining of this and you see this on examination, the more time that you waste delaying them from getting a biopsy and steroids can lead to blindness, which is an emergency. So the correct answer is A. All right. That surprisingly puts us at 25 minutes, a little bit longer than what I thought it would take. Again, I'm going to go ahead and there's 25 questions altogether. If people like what I'm doing, I will continue to post explanations for all of these that we can go over together. I know I may be putting it a little extra long, but again, I don't know where the base is for everyone's comfort level on all these questions, so I'm going at it kind of low and slow and working our way up with some test taking strategies. If you guys have any questions about some specific questions that you may have seen on other practice exams, feel free to send them to me, and I will be happy to take a look at them and post them on a later video. Later tonight, hopefully I'm going to be able to go ahead and do vent management and pulmonary physiology and how that enters in together. So look for that hopefully later tonight or possibly tomorrow, depends on how I do tonight. Thanks so much.